Good evening, and thank you for inviting me to speak with you tonight about ethical implications of the COVID-19 pandemic. These are my views and not those of the NIH or the U.S. government. I wanted to start by recognizing that there are very many challenging ethical issues in the COVID pandemic, and that some of them are familiar and some of them are new, and they cover a wide range of domains of ethics: clinical ethics, which has mostly to do with patients and healthcare providers and healthcare delivery; public health ethics, which is population level issues; and research ethics of protecting research participants while promoting. I thought it would be helpful to remind everybody what bioethics is and is not. Bioethics is not a set of rules or laws, but rather a systematic, structured approach to clarifying and addressing ethical issues in clinical practice, in healthcare and public health, and in research, using principles, scientific evidence, stakeholder values, and others. It's a field that's rooted in moral philosophy that examines ethically preferable and justified approaches to situations, our responsibilities to others, and how we ought to be in the world. So looking at some of the clinical ethics issues, I'm going to talk briefly about healthcare worker responsibilities, risk and realities, end-of-life care, and moral decisions. From the beginning, taking care of COVID patients has had a number of very challenging realities. First, providing quality patient care in times of crisis when the demand often exceeded the capacity, even after surge efforts to try to increase capacity. Couple that with fear and concern about their own risk and well-being, and often inadequate supply of personal protective equipment, staff, beds, ventilators, and medications. Sometimes they were caring for ill colleagues or friends or neighbors, and often the patients and the families and the staff were distressed because they were afraid, they didn't know what was happening, and they were confused about what was going to happen next. So this raises the issue of the responsibilities of healthcare providers. Healthcare providers have a moral and professional obligation to care for patients, even in the face of difficult circumstances and some risk to themselves. And this is based on general positive duties to help others, but also specific role-related positive duties that healthcare providers are trained for and take an oath for to provide care to patients. But these obligations are not absolute. And they're not absolute because sometimes the risk or the circumstances are too difficult. And so the question here is where the responsibilities were limited. There's also clearly responsibilities of healthcare organizations and other institutions to provide healthcare providers with the PPE that they needed, with the guidance that they needed in order to provide, and the staff that they needed in order to provide healthcare to their patients. So now that we're in February of 2021, we realize that some of those concerns still exist in certain places, but there are new ones. There's now a year into this pandemic, cumulative grief, long-term emotional, physical, and moral distress experienced by healthcare providers because of the frequent death of patients and friends and family, the marathon of providing care to large numbers of complex patients, the sometimes being asked to work outside of their comfort zones. And we've learned that visitor restrictions, although put in place for good reasons, provide an amazing amount of emotional and moral distress to families and to providers. In addition, there's now well-documented COVID fatigue and denial. There have been inadequate staff situations, but also people have been furloughed because of reduced income on the part of healthcare facilities, and so economic distress that individuals are facing. There's a rapid uptake and continuing use of telehealth, which is positive by many people's experience, but completely new for others. There have been tragic choices that they've had to make or witness, and there's a continued concern on the part of healthcare providers about the non-COVID patients that are either not getting enough care or are getting care in a delayed fashion. As we know, sadly, this past week, the U.S. reached a grim milestone of 500,000 deaths, so 500,000 people who have died from COVID in the United States. So what this means is that death has been very frequent, and it's also been very lonely. People have died alone in hospitals, in healthcare, in long-term care facilities without their families present and with nobody but the healthcare provider by their side. We've recognized the need for paying attention to advanced care planning, and there have been efforts to try to get people to put together advanced directives and state their preferences as early in the disease as possible. And there's been an increased role for palliative care and other healthcare staff like pastoral care and clinical ethics providers to both support patients and families, but also healthcare providers, clinicians, nurses, and doctors. We've seen a dramatic increase in telehealth. And I think this statistic is just staggering. CMS reported that between March and April of 2020, so that's over almost a year ago now, there was a more than an 11,000% increase in that 1 month in Medicare virtual visits. That has definitely continued. There's been shifts up and down, but basically telehealth is here to stay. I noted in an article that was published in the Journal of the American Academy of Dermatology in May that both recognized the quick response of providers to adapt to and change their way of practice to endorse telehealth, but also raised some of the enduring questions that come along with that. Like, will telemedicine provide the same quality care as in-person medicine? And how do we foster patient relationships when we're electronically distant from people? Many of these realities had left with healthcare workers in crisis situations that have experienced moral distress and mental health problems. Because they've had to live with decisions that they made or they witnessed and things that they did not want to happen, whether or not they agreed with them or understood why they were happening. And all of this has been really exacerbated by COVID denial, fatigue, and frustration. I've had many healthcare workers poignantly say to me, they're committed to their patients, they're committed to their work, they work really hard day after day for the entire year, but what makes them almost want to not go back to work is when they have a patient in the clinic who just tested positive for COVID, or in the ICU who's dying of COVID, who denies that COVID exists. And then they go outside or they go home from work and they see throngs of people on the street with no masks and no effort to try to protect themselves from COVID. Turning to some public health issues, public health ethics issues, there's a few that I'd like to mention. The shifting to crisis standards of care, resource allocation and principles of allocation, vaccine distribution and hesitancy, and inequities in decision. So first of all, there's been a lot of attention on crisis standards of care. This is a understanding that during an emergency, we might have to move from a general conventional level of care to a phase called contingency care into crisis care. And conventional care is the everyday healthcare services that we provide all the time. Any of us who are healthcare providers know that sometimes those feel like crisis, but this is a very different situation. Contingency care is the next level in the continuum when the demand for staff, equipment, or pharmaceuticals begins to exceed the supply. And in contingency care, the effort is to try to continue with functionally equivalent care, recognizing that some adjustments will need to be made, but also spending time surging capacity, so bringing in extra beds, extra equipment, extra staff, with the hope of avoiding the need to go into crisis care. Crisis care is when the resources are so depleted that functionally equivalent care is no longer possible, and people have to make choices that are not necessarily conducive with what they're usually doing in health. So clinicians, such as physicians and nurses, are trained to care for individuals and to put the individual benefit of the individual as their primary goal. In public health emergencies, they're often required to change that practice to respond to the care needs of the populations and to allocate scarce resources in order to prioritize the community. And this shift from patient-centered practice to patient care guided by public health duties creates great tension for clinicians. The National Academy of Science, Engineering, and Medicine had put together some very helpful guidance on crisis standards of care in 2009 during H1N1. In early 2020, they revisited some of that guidance to try to update it to respond to the COVID pandemic. And there is lots of very useful information there. One of the things that I really like is this paragraph, which points to the vital importance of adhering to core ethical principles like fairness, duty to care, duty to steward resources, transparency in decision making, consistency, proportionality, and accountability. And this is directly from the National Academies. So during COVID, we have had to figure out how to allocate beds, ventilators, staff, personal protective equipment, and in more recent times, although some institutions are still dealing with the beds and staff allocations, but more recently we've had to really struggle with allocating medications that are scarce and vaccines. This was a paper that was published early in, I think, in March of 2020 or April, which laid out some of the ethical values and guiding principles of fair allocation or rationing. And maximizing benefits and treating people equally are the two that you'll see come up over and over and over again. And they applied these to COVID. In this ensuing month, many groups at the level of hospitals, at the level of states, at the level of other political entities, have put together guidelines for allocation of scarce resources and crisis standards of care. And over, there's been agreement about some of the most important aspects. So you'll see again, maximizing medical benefit as one of the important goals that everybody tends to agree with, as well as treating people equally, which involves avoiding discrimination, but also minimizing or to some extent mitigating disparities. Almost everybody agrees there should be allocation teams or triage teams that will make these decisions rather than the treating clinicians in order to avoid conflicts and minimize moral distress, that there should be transparency and communication with patients and families, and that it is important to engage the public. There are, however, lots of issues that get continually to be debated. So one is what is the best way to maximize benefit? Should the principle be saving the most lives, and should we then prioritize short-term benefit, in other words, discharge from hospitalization? Or is the goal saving the most life years, in which case we might take into account age, comorbidities, disabilities, disparities, and give preference to some of those. Questions about what is the best way to treat people equally? Some people believe first come, first serve. If you're there, you get the services. Someone else comes in, they're out of luck if there's no more left. Others believe that first come, first serve disadvantages the already disadvantaged and therefore promote lottery systems, including sometimes weighted lotteries, but these are controversial. There's also been debate about the extent to which instrumental value and reciprocity should be recognized in these guidelines and in these decisions. So instrumental value means, healthcare workers and frontline workers, we need them in order to continue to care for patients and to provide the services that are considered essential in our society. Reciprocity might be a recognition that these people are putting themselves at higher risk than others, and research participants might fall into that category as well. But these are controversial ideas. These allocation principles have also found their way into decisions about vaccine allocation. And many of you know that months before there was vaccine even available, there were a number of different groups that spent time putting together allocation frameworks, including the Strategic Advisory Group of Experts at WHO, the National Academy of Science, Education, and Engineering and Medicine in the United States, and the Advisory Council on Immunization Practices, which makes recommendations to the CDC. There are also a number of academics that put together allocation frameworks. And you can see, although the words are slightly different, that the values that they prioritize seem to be consistent, maximizing benefits and equal regard for individuals, but also fairness, transparency, and a couple of others. These proposed frameworks led to recommendations that the first priority for vaccines and people in nursing homes. And in fact, when the first person in the United States to receive a vaccine once it was authorized under emergency use was a nurse, a critical care nurse in New York City. And she did so publicly and proudly. Despite there's plenty of data that shows that members of the public, but also healthcare providers, and very specifically nursing home staff, have limited willingness to accept vaccines. And the surveys of willingness, but also data on actual vaccine uptake show that about a third of these groups in many surveys are not willing to take vaccines. Others are unsure, and the rest are clamoring, trying to get vaccines when sometimes they can't. Of course, these are changing as vaccine becomes more available and attitudes are changing. What are some of the reasons for unwillingness or uncertainty about accepting a vaccine? Certainly concerns about the speed with which those vaccines were developed, the politicization of vaccine development and some of the hype around that, the lack of clarity about the process, misinformation and disinformation about vaccines and what they do, peer influence, and generally lack of trust in research or in government. One, I think, very important survey that was done in October of 2020 with almost 13,000 nurses done by the American Nurses Association found that if you look at this last row here, only about a third of the cohort said that they would be willing to take a vaccine if their employer did not require it. And about a third said they were unsure. They'd be somewhat willing, and some said they would not be willing. The reasons given were that the vaccine development was happening too fast, that they weren't getting enough information about the vaccines themselves and the details of them, that they weren't clear about the COVID-19 clinical trials process or the approval process. All of these things could be addressed through information. But these are nurses who not only are being invited to get vaccines, but also serve as advisors to patients and others. So as data has emerged, vaccine hesitancy has clearly shown to be a problem. And the amount of disinformation that is out there is also a problem. The good news is some data have shown that since December, or between December and January, the percentage of people who were very willing to get a vaccine, in fact, wanted to get it as soon as possible or had already gotten it, increased in that month. From 34% to 47%. That's encouraging news. There's also data that shows that the willingness to get a vaccine or the interest in getting vaccines varies by age, but also by race and politics and where you live. And these are things that have created some consternation. For example, that the number of Black people who are willing to take a vaccine is lower than other groups. This is unfortunate because when we look at the data on the disparate implications of COVID, we know that people who are people of color, people who are Black, or people who are Hispanic have a much higher incidence of COVID and a higher hospitalization rate and death rate from COVID. And this is true because of, or attributed to, underlying conditions that impact health, including socioeconomic status, access to health care, and increased exposure to the virus due to, for example, their occupation, that they're frontline or essential, or have jobs that put them at risk. This disparity is also impacted in delays in care for non-COVID patients. So an important study that was done and published in the MMWR in September showed that 4 in 10 U.S. adults reported avoiding medical care because of concerns related to COVID, that this led to a range of negative health outcomes, but also included the possibility of increasing existing disparities because the delays were more prevalent, or avoidance was more prevalent, in people who had underlying conditions, who were Black, Hispanic, young, or had disabilities. But I'm going to turn with some selected research ethics issues. I think everyone would agree that there's an ethical imperative to research the epidemiology, natural history, pathophysiology, clinical manifestations, social consequences, and to identify preventative, diagnostic, and therapeutic interventions for COVID. And this, from the outset, was seen as an urgent responsibility, but also a complex responsibility. And I think most would agree that research has proceeded at unprecedented pace since then. In dermatology, I've noticed that there have been several papers, for example, that have talked about the cutaneous manifestations of COVID and their implications for dermatology. What are some of the research ethics issues? So certainly urgency and complexity sometimes is contrasted with rigor and trust. In other words, if you're moving too fast, can you keep up the amount of rigor in science and therefore the trust of the public in the scientific results that are forthcoming? There's been a lot of attention for the need to avoid compromising ethics or science, to evaluate the trade-offs between urgency and rigor, to set priorities in order to make sure that this is done well, and that set priorities at every level, funding levels, national levels, but institutional levels as well. To emphasize collaboration and coordination so that resources can be shared and things are not duplicated unnecessarily. There's a lot of really interesting and challenging issues related to human trials. One is how do you conduct human research in clinical settings that are so busy they can't take care of the patients that they need. And now we're seeing a shift in that. In some places, the COVID units are closing or the amount of hospitalizations have decreased, luckily, but that's going to create recruitment challenges for clinical trials. There's an interesting selection of participants problem, which is the opposite of our normal problems in terms of recruiting people, that sometimes more people who want to participate than there are slots, and there needs to be fair processes for deciding who gets to participate. And informed consent is a challenge, especially when people are very ill or incapable of giving their own informed consent. Then, of course, a need to rapidly communicate with the public. Many people recognize the need to not lower scientific standards or ethical standards in the context of doing research. Last, I just want to touch on a very important issue about public engagement and communication. That in a society like ours in the United States, where science and health literacy are limited, and there's lots of reasons that people are dubious about their trust in science, and including in the hype and politicization. The need for public engagement and communication about science, about the process of science, about the processes of approval, and about the results of our scientific protocols is absolutely critical. So to end, I want to recognize there are many, many complex and evolving ethical issues in clinical and public health and research arenas. I've only really touched the surface of most of them and only highlighted a few of them. I just put this photo here to remind us that spring is coming and there is some hope in the future for better days. Thank you very much for your attention.